Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining me today, our regular guest, Dr. Rob Dixon.
Hey, buddy.
And our Division Chief of Clinical, Nick Smith.
Good afternoon.
If I sound hoarse, maybe like I've been talking about this exact topic for the last 2 months, it's because we have. We're going to talk today about some recent ketamine protocol changes here at MCHD. But again, things that make me excited probably aren't the same thing as most normal people out there. But I went to get a salad for lunch today. This is an honest-to-God true story. And I received a text from one of our MCHD in-charge paramedics, one of our really savvy clinicians out there. I got to give credit to Jason Jones. Sent me a PubMed link to an article. He scooped me off of Twitter even. You can tell I've not been on social media this morning. The title of the paper that we're going to talk about in relation to our protocol changes is Fixed Dose Ketamine for Prehospital Management of Hyperactive Delirium with Severe Agitation. This was by Michael O'Brien and his colleagues, Dr. Clemency as well, up in Buffalo. And it's just really sometimes crazy how things happen and you perseverate. We've talked about this as a group multiple times over the last couple months, related to our ketamine protocol here at MCHD that's been here for longer than I've been here, longer than either of y'all have been here, and giving credit where credit's due all the way back to Jay Kovar, is an EMS visionary and brought ketamine to Montgomery County, rightfully so. For our most dangerous, our most agitated patients, this is the best option for them. This is the safest option for us as medics, and it really balances that line between patient danger, medic danger, and immediate sedation with hemodynamic stability maintained better than any other pharmacologic agent that we have. Now, that said, it's not safe. It's relatively safe. It is a dissociative anesthetic. And if you've watched the news or you followed ketamine and EMS over the past several years, you know that there has been a lot of discussion and there have been some very unfortunate cases. And so our goal today is not to rehash any specific case, but it's to talk about how we here at MCHD decided over the last really 8 weeks or so to try and improve our protocol to reduce patient risk, to reduce medic risk, ultimately to go back to rule number 1 here in the MCHD clinical house rules, and that is patients are our foundation. And it was a lot of thought trying to get to our end decision. So, Chief Smith, talk to the listeners about the protocol changes that we made first, and then I want to bring in Jason's article that he sent me, because it's always good to have some confirmatory data, other smart folks out there maybe doing the same things to validate our decisions. So let's talk about our ketamine protocol changes. For the non-MCHD listeners out there, sorry, this is our educational podcast. I'm talking to our medics. We're talking to our medics today, but hopefully there's a shred of truth and some pearls that everyone can learn from here.
Yeah, so we recently made a change here at MCHD in the way that we have our ketamine administration. Specifically for our behavioral sedation patients, those with a RASS of +4, we've gone to a fixed dose with the dosing of 100 milligrams IV or 250 milligrams IM. That dose is now Q10, so we've extended the length of time between allowable doses prior to initiating consult, or if the patient has severe agitation, again, RASS +4, the clinical circumstances call for it, and they weigh over 100 kilograms, you can consult with a district chief for a one-time single 500 milligram IM ketamine dose.
And why did we do this? We did this because there is loads, heaps of data looking at weight estimation and weight-based dosing errors in the hospital, in the ICU, especially in EMS. We have a patient with a RASS of 4, and we're trying to estimate a weight and draw ketamine and give a dose. The entire concept behind this is to give a dose that's safe and reduce medication overdose and medication errors. I'm going to repeat Nick's dosing again just for the MCHD listeners so they hear it again. 100 milligrams IV, 250 milligrams IM for patients with severe agitation, RASS of +4. That can be given Q10 minutes as needed for severe agitation. If the patient requires quicker dosing than Q10 minutes, that can happen. It requires a district chief consult. Put two heads together, run the checklist, consider the necessity, consider the options. The second district chief consult available is in that off chance that you have an extremely large patient with extremely large agitation, greater than 100 kilos, RASS of +4 or higher. It doesn't go higher, I'm aware of that, but the extremely high end of that +4, then a 500 milligram IM dose can be given with a district chief consult. Chime in.
Thank you. I'd love to dumb down. I'm going to dumb down the RASS score, which is the Richmond Agitation Sedation score, and just I think really clarify what Chief Smith said, which is first and foremost, this is a very sick patient population. We would not pull out this tool, this quiver or arrow from the quiver, in a patient that wasn't in this sick population. So if you look at this, whatever term you put with it, severe agitation with delirium, these are people who, regardless of mechanism, it could be traumatic, it could be a toxin. There's lots of gnarly players here. It could be a head trauma, a head bleed. It could be encephalitis, meningitis, and on and on and on, right? The reasons that we need to make sure that we can adequately assess these patients and treat them. That's first and foremost. So to begin with, this is a very sick patient population. Before we do anything and do one intervention, then we're giving them an anesthetic. And as Casey said, it is the safest of what we believe the anesthetics available to us for immediate control. But that being said, it is an anesthetic. So we'll hark back to, for MCHD medics, the rule of 15, got to be in place as quickly as we can get it. Moves, got to be in place as quickly as we can get it. So full monitoring, supplemental oxygen, vascular access, vasopressor support, all those things, sugar and sedation plan once we get control, and then we start working through the algorithms. And that's my little opine. Before we jump into the paper, I'd just like to be clear about how sick of a patient population this is and how important this is to begin with, that lots of these patients are not going to have great outcomes to begin with.
And you can do mnemonic soup here. Snores as well.
Yeah, snores.
SpO2, nasal cannula end tidal. Turn up the oxygen. You got to have a RASS of +4 to warrant ketamine sedation moving forward here at MCHD. Get a 12 lead, think about toxins. Get a sugar, think about endocrine altered mental status serial killers. And we have had that case. The patient who was altered and disruptive and dangerous and flailing and at risk to themselves and our medics. Ketamine sedation to find a sugar of 36. Those stink, but I'd much rather find the 36 in the truck and treat it than deliver that to the ED.
I 100% would.
Absolutely.
And if you want to dumb down the RASS and you're not a great one with all these things, right? If you walk into the room or walk onto the scene and you look at a patient that is so altered, so agitated, you can't put a blood pressure cuff on, you cannot treat them, you can't get a blood sugar, you see no other thing to do than gain immediate control. That is a ketamine patient. That is a RASS of 4 for a layman's person such as myself.
And I would just encourage the MCHD medics to review the PDF in the show notes and be familiar with the definition of +4, and that is severe, immediate, combative danger.
That's not the one where you're looking and going, well, I could do this or I could do this, right? If you have to think about it twice and think, well, gosh, I could maybe do this, or I could get him a cup of tea and a blanket, then you need to rethink using this medication.
Yeah, these are very sick patients, I completely agree. And one of the reasons that we have a few more guardrails on with the protocol, such as age, is because they are sick. They're very fragile. If that patient for the MCHD medics is 10 or less or 70 or greater, that also requires a consult with the district chief, because we want to make sure we're providing the right sedation for the right patient given their circumstances.
Yeah.
So let's run through the protocol changes one more time for the MCHD listeners, and then we're going to talk about some other caveats and some other discussion points that we've hit on through this process over the last couple of months, and we'll briefly touch on the article as well. 10 or less, 70 or greater. If that patient requires ketamine for sedation and a RASS of +4 is present, consultation is still required with the district chief due to the significant high-risk nature of that patient. For the non-MCHD medics out there listening to this podcast, historically, ketamine administration for agitation has not required district chief or medical director consultation. Moving forward, age extremes will require a district chief consultation. Dosing is going to move from a fixed dose from a weight-based dose in attempt to decrease medication errors. 100 milligrams IV or 250 milligrams IM may be administered for RASS of +4, Q10 minutes as needed for said RASS of +4. If the medic feels like a quicker redose is needed, that can be done with a district chief consult. If we have an extremely large, extremely agitated patient, greater than 100 kilograms, RASS of +4 on the farthest end of +4, then a 500 milligram IM dose can be administered. However, that requires district chief consultation. So that's the gist of our protocol changes here at MCHD. For our medics that are listening, thank you for listening and continuing to educate yourself. There are some other topics and some other teaching points that I won't say pivoted on, but I've definitely reconsidered through this discussion. And one of those things that you just mentioned, Dr. Dixon, was if you think there might be another option, if you think maybe this or ketamine, it should probably not be ketamine. I would say going forward, it shouldn't be ketamine. It should be the other option. And our two options here within the service are midazolam and droperidol. And one of the myths that I want to bust today, and I'm sure this came from both of us talking about this over the years, and while we agree on most everything and have very similar medical philosophy, we are two different people, and sometimes things can get lost in translation there. And that is the thought that droperidol is just for patients with a mental health crisis and or psychosis. It is perfect for those patients, but it is wonderful for undifferentiated agitation as well. It's not just for patients with a history of schizophrenia. So let's knock that one out, push that one out of the way. There are some folks that droperidol is not indicated for, and I would go so far as to say it is contraindicated for. And let's talk about those three groups. There are three groups, I believe. That is a patient that is post-ictal and agitated. Why? Because if a patient just seized, odds are they're going to seize again. Let's give them the seizure sedative. Secondarily, droperidol also lowers seizure threshold, makes it more likely. Probably don't want to make their second seizure more likely. So post-ictal agitation, midazolam. Withdrawal from alcohol or benzodiazepines, Klonopin, Valium, Xanax. Insert benzo. Those patients need GABA action. Where do we get GABA action? We get GABA blockade from midazolam. So a withdrawal patient, benzos or alcohol, is a midazolam first patient every single time. And then the last group is the sympathomimetic overdose patient. Who are those? That's crack, meth, cocaine, speed, PCP, those known sympathetic surge patients, tachycardic, diaphoretic. I just ate the baggie of meth crystals. That patient will be better served with midazolam as well.
Yeah, and I would add in there, just be careful if the case has a big tox flavor, it steers me more towards midazolam. I'm not saying that, there's lots of ingestions out there that are polypharmacy ingestions. They may have an effect on the QRS. I don't want to give a medication that may prolong the QRS when I could give a safer one. So remember, like Dr. Patrick was saying, a tox feel to it, whether it's sympathomimetic or just agitation with a toxic feel to it, like a tox case, it pushes me more towards midazolam, guys. I just think it's safer overall.
So spilled pill bottles,
Yeah.
large ingestion, unknown substance, known meth, cocaine, crack, speed, insert street name, PCP, midazolam would be your drug of choice, and the toxicologists of the world out there would applaud you for that. So that's really just a review of the other, an aside. But getting back to ketamine and choosing these patients, we had lots of issues that we were trying to address with these protocol changes, and that is, how can we use the positive pieces of this drug while still reducing the risk for our patients? And so age extremes, be considerate. Medication dose errors. We've talked about medication dose errors on the podcast before. We talked about this ad nauseum in CEs, in In-Charge Academy, in NEOP, in on-the-road CE scenarios here at MCHD. We have to do a medication cross-check. Several of the errors that we've seen within our own service have been despite a medication cross-check. So if we know weight-based dosing is hard, moving to a fixed dose seems to be the obvious answer. And lo and behold, accepted April 8th of 2024, forwarded to me at lunch by Jason Jones, fixed dose ketamine for pre-hospital management of hyperactive delirium with severe agitation. And reading the abstract in the intro, Chief Smith had the same comment I did. Hey, this is exactly what we just did. So what did they find? And this is not meant to be a journal review podcast. This really is just a situation where we were all planning on recording today, and this came across to me, and I thought, we have to talk about this because this is perfect. They found in this study, what they looked at was they looked at a protocol change. This is a similar work to what we do. They wanted to fix the same problem we are fixing, and that is they want to reduce the risk to the patient for medication overdose and receiving large doses of ketamine. So in New York, a single hospital system, 4 EMS systems underneath this umbrella, the same protocols. They had access to hospital medical records. When they moved to a 250 milligram IM fixed ketamine dose for agitation in the field, they looked to see what happened. Did they have any bad outcomes? What were the patient's weights after the fact? Because they had hospital outcomes, so they could look at the bed scale numbers, real weights, and how many of these people were intubated. Were the patients that were intubated, did they get discharged okay? And not to delve into the stats or into the details, there are a couple points that I believe are really, really vital for us in this discussion and make me feel better about the decision that we made and the changes that we made here. 60 patients during this study got ketamine for agitation in the field via standing order that were adults. There were other ketamine doses given for, I would assume, things like RSI, DSI, probably maybe for, say, cardioversion or procedural type sedation. No pediatric patients were included. If the medics talked to the medical director first, those weren't included. That all makes sense. We're looking at how does the standing order function. So they had 60 patients. Cool point number one for me, only 12 of the 60 required a second dose. So
20%.
My math's not great, but 48 patients got 250 IM and rolled on to the hospital. That tells me that it worked pretty darn well. That is a really telling number. The second piece is none of the patients were intubated in the EMS setting. A few, 3 required BVM, 1 was suctioned, but didn't require any other EMS intervention. That sort of fits what we know. Now, there were some patients intubated in the ER. I don't always trust those because I don't know that Even today, all ER docs have the same level of comfort with ketamine field sedation.
And let's go back to how sick of a patient population this is to begin with, Casey, because part of the intubation decision, if you go back to I'll plug the patency versus protection podcast, is what is the patient's anticipated clinical course? We have more insight on that because we have more information in the emergency department. With each step in the care system, we gain more insight and information. So I don't think it's necessarily a failure to say in this terribly sick patient population that a small percentage ultimately got intubated. I think the better part of that is all that did get intubated survived with normal neurologic status.
So others are out there trying to solve the same problem that we're trying to solve via the same method. Makes me feel solid about our decision. I believe 250 is a great place to start moving forward. It's always reassuring to see other smart folks doing the same thing. Had no idea this was in play in upstate New York, but we're about, 2 weeks in now post-protocol change?
Yes.
And like everything else we do around here, it's always a work in progress. We will be tracking our data in much similar way as Dr. Clemency and their group, and hopefully we'll see the same results, and that is that 250 milligrams IM as a fixed dose will be adequate for most patients with a RAS of +4 in the pre-hospital setting. Safety will be of the utmost importance as we continue to review and analyze this protocol. Are our patients getting intubated? How much vomiting and suction need, BVM need do we have? Hypoxic events? Did we get snores in place after sedation? That's a metric that we watch every week anyways. We review all of our ketamine sedation charts 100% here at MCHD. None of these go without 2 eyes, most of the time 4, including mine, looking at every one of these charts, and these are a part of our Tuesday clinical review every single week. So while the MCHD listeners are going to see a protocol change, the behind-the-scenes portion and how we watch these, other than even more closely than normal, shouldn't change going forward. Anything else y'all want to add? I'm going to wrap up with the protocol changes for the listeners. Hopefully this is some good spaced repetition for y'all out there at MCHD. We are not going to we're not going to stop talking about this anytime soon. One of my pet peeves is when medics tell me that we only talk about ketamine and sedation and airway management, and I say, yep, that's because we're doing it right. Those are the highest risk patient decisions that we make every day. Those are the ones that we can have absolute catastrophic impacts on patients if we do it improperly, hastily, without monitoring, without a safety net. So yes, we're going to talk about these until I'm done sitting in this chair probably. So let's roll through the protocol changes. 10 or less, 70 or greater, can receive ketamine for agitation, but only with a district chief consult going forward. All ketamine agitation patients must have a RAS of +4. If they do not, other sedation means should be considered. That includes midazolam and droperidol here at MCHD. When we have a patient, RAS of +4, 46 years old, and our medics arrive on scene, our fixed ketamine agitation dose going forward is 100 milligrams IV, 250 milligrams IM, which may be repeated PRN every 10 minutes. If that medication is needed sooner in a repeat dose, that requires a district chief consult. If we have an extremely large, extremely agitated patient, greater than 100 kilos, +4 on the upper end of that +4 agitation, a 500 milligram IM first dose may be given, but only with a district chief consult. Gets us right up towards the edge of our time. As always, thank you to the listeners out there. If you have questions or concerns or thoughts about this one, please email us podcast@mchd-tx.org. Huge thanks to Dr. Dixon and Chief Smith for the time and expertise and advice and multiple ears that they've lent me over the past 2 months regarding these changes. In the end, our ultimate goal is to keep our patients and our medics and Montgomery County as a whole as safe as possible in these exceedingly difficult, exceedingly critically ill situations. Leave us a like, leave us a review wherever you listen. We'll be back again with a new episode soon.